Good morning.
Good morning. Now it seems like I haven't seen you in forever. Just a few days, but good morning, Dr. Rosensweet.
Good morning, Carolyn.
It is nice to see you. And I, as always, have these questions that we get to get answered. And I find that very exciting. I'm hoping you're well.
Absolutely.
Good.
Very well.
Good. Happy to hear that. Okay, so question number one. It's a little bit of a revisit. Women really enjoyed our last interview. And so we have a little bit of a revisit. Question number one is coming in saying, taking the right type of estrogen can really help mood and symptoms, as we've often talked about. But this woman is asking, how do we know what kind of estrogen it is that's right for us?
Well, the very best answer would be for them to download the PDF copy of the book that you've put up on Ins and Outs of Menopause.
Absolutely.
You'll get the full description, but I'm going to give you the short version now.
Okay, thank you.
For several reasons, the estrogen that should be chosen is topical. That means you apply it to your skin or mucous membranes, that's for sure. Not estrogen oral. There's reasons for that. Topical estrogen, and the optimal form is biased. That's a combination of estriol and estradiol. And that more copies then will result in a testing profile that will mimic in ways the natural configuration of estrogens in a young woman. We're not trying to replicate youthful levels.
Right.
But as far as what the estrogen family looks like, it will look like the profile of a young woman as far as distribution of the three estrogens and the metabolites. So biased is the formulation. We 100% start out with an 80% estriol. Oh my goodness, 20% estradiol. That means we're putting 4 times as much estriol in that biased formulation than we are estradiol. There's reasons for that. 80-90% of the women will stay with an 80-20. And then you begin with a biased dose that's rather lowish, and you gradually increase that biased dose, alleviating symptoms of insufficiency, while falling shy of or backing down from symptoms of excess. Once clinically a woman feels a lot better, we do a 24-hour urine hormone test, not other tests, not urine 5 points, nothing like that, 24-hour urine hormone test. And that's where we get to see what's really happening. And then, 75% of the time we'll do a minor tweak, because if a woman has arrived at a dosage that she feels good with and symptoms are alleviated, 25% of those women will be in what I consider to be the optimal zone.
Right.
And 75% won't. 25% will be on a little bit too much, and 50% will be on a little bit too little. And so biased is the optimal estrogen to be treated with topically, that apply to skin or mucous membranes, and then eventually tested to oscillate into or tweak into the optimal zone. And we have defined that zone very carefully as far as estrogen family goes, very precisely. So there's rare exceptions, but that optimal zone is important from our perspective.
It's a question I do get often. Throwing it in quickly. Women will say, what is the optimal dose that I need to get to? And I've never been able to answer that. I've asked it. I've never gotten an actual answer. I understand it now. I'm going off a little bit off subject, but it is what is optimal for that unique woman. Am I correct?
Precisely. There is no way to absolutely get the perfect dose prescribed, because there is such profound individual variation woman to woman.
Yes.
So no big deal. We assist every woman to oscillate into her optimal dosage of estrogen and progesterone and testosterone and DHEA. And it's a lovely process to do so, and it's described in significant detail in our book, Happy Healthy Hormones. And, there's a wide range. Like in my practice, just with respect to estrogens alone, some women at the low end of what they need will use 0.8 milligrams of estradiol equivalent of bias. Oh, I'm not going to define what milligrams of estradiol equivalent is today, but that's the potency, the estrogen potency. At the other end, some women will need up to 2.6 milligrams of estradiol equivalent. And
Right.
then somewhere, every woman's going to land somewhere in that spectrum. That's a wide range, 0.8 to 2.6. And there's even outliers from that. There's even women who require more to actually alleviate symptoms and will wind up in the optimal zone to protect their bones, their brain, their vagina, etc. So there's no big deal that there's a wide variation woman to woman. We start with this process. We start low, gradually increase the dosage. Woman feels better. We test her. So no big deal.
Okay. Well, you make it sound very easy, and let us all feel well.
Easy. Well, it gives you an insight into how profound the human female and male body is created and how intricate and what an orchestration goes on there.
Yes.
How phenomenal it is that everything lands pretty good in young people. But when the ovaries stop producing, we want to come in and identify to the best of our ability that individual woman's proper dosage level of estrogen, progesterone, testosterone, and DHEA. We're trying to do what your brain, your hypothalamus, your nervous system, your multidimensional being did automatically. Well, we're trying to replicate nature. And we can do a good job with it, but sometimes it's not so fast as, here, take this, see you next year. No way, never happened in my practice.
No.
For example, in the menopause method, we spend hours during the first year. I'm not even going to reveal how many. It varies woman to woman to oscillate into the optimal dosage, and because we want to get it right. We want to get it right for your body. We want to individualize. Oh, did I say the word individualize? I think I did say individualize. So you haven't been able to tell women, well, what's the right dose, because it's untellable.
It's untellable.
But we do know what to start women out on, and we make choices around that. In the intake process, we're trying to determine, among many other things, whether a woman falls into the category that we call most common, and we start out on a technically dose determining schedule that's very common. 75% of the women land in the most common. But there's sensitive women out there. And who are sensitive, you know what I'm talking about. You know what that means. So in our initial intake, we're efforting to make a determination, because if you're a woman who's sensitive to everything, we're going to start on a different protocol with you. And then there's some women who are so fresh into menopause or perimenopause, and their bodies are used to very robust levels of estrogen. So we make a third determination. If they're one of those women whose bodies are very used to robust levels of estrogen, well, we start out a little more aggressively. So you can't tell, and I can't tell which one to prescribe, which one of those three particular initial dosage regimens, determination regimens to prescribe, until I go through a woman's full medical questionnaire. And we spend, during the first visit, between 1 and 2 hours learning about that woman before we come up with, 1 or 2 hours, think about it, before we come up with the optimal way to start off on their estrogen program and their testosterone and DHEA and progesterone program. So I can't even say, without really interviewing the woman and really understanding all the details that are in that questionnaire, what initial dose to prescribe.
Well, yeah. And it brings us back to what we always talk about and how important it is that menopause be recognized as the specialty that it is.
And individualize the women. That's it. You put in the time, the care, the rigor, and this is how you get a program that is going to really serve a woman for 10, 20, 30, 40 years. Oh, that's what we're talking about. So we want to get it right. We want to dial this thing in right. And although the first year is time intensive, annually, if the most that's done is some tweaking, sometimes not even tweaking once you're dialed in.
And it feels so much better to feel better. That is definitely for sure. I'm gonna welcome everybody and our Facebook users, Brooke, and other Facebook users, Liza, and someone from Hawaii. Well, good morning, everybody. We're happy to have you here. I'm going to move on to question number 2, if you don't mind. And that is, I am wondering if there's a particular time of day best to take DHEA, and do we take it daily? I am trying 5 milligrams now. I struggle with hirsutism, and we'll start off twice per week. I'm really sensitive, and I'm very scared the DHEA is going to lead to my getting alopecia, which is loss of hair, if I'm correct.
Well, for most women, DHEA is pretty easy. And yet, because it's a pro-hormone or a hormone, it's the kind of thing you don't want to figure out yourself. You want to be under the care of a professional who is specializing in the world of hormones. These are such powerful biochemicals. And in general, just to put out some guidelines for women around DHEA, anyone in menopause is going to need it because they're a lot lower than they ever were. The ovaries are a major source of DHEA, not the only source. The adrenals are as well. And those ovaries are going to stop producing DHEA, and you want it. And here's some guidelines around usage of DHEA. It can be given orally. We always start out topically, and when we get the good numbers, we stay with topical. But it can be given orally, and if you're taking it orally, no woman should be exceeding 15 milligrams of DHEA a day, and that can be a little robust for some women. Now, for the questioner, if you're getting hirsutism, which is additional hair growth, some of which may be unwanted, for example, in the mustache or chin area, then you've got a delicate balance with DHEA, and I'm glad that you're concerned about it because you want to get that one right. And one thing that's not right is if you take DHEA and you start getting additional hair growth, something is not right. But again, always what I recommend is get with an expert, because it isn't just DHEA we're thinking about here. We're thinking about estrogen, testosterone, progesterone, and DHEA, and also we include in our method thyroid hormone because so many of us are functionally deficient in thyroid around midlife. We can use to have thyroid replenished as well.
It's interesting you say us. I'm thinking you're including men in there.
Well, I'm slipping in men too because women lose hormones. Your peak output of your ovaries was at the age 20, and you decline from that moment on. Well, men do too. As the world got to experience when Viagra was invented and became one of the most popular drugs for men. Why? Because Viagra can restore a semblance of erection to a man. And when Viagra became enormously popular, what did we learn? That millions of men were having erectile dysfunction. And in men, the core of erectile dysfunction is inadequate testosterone. So men are losing their juice as well. And of course, we're now in the process of developing a very thorough program for men. And I've been the experimental person, and I'm taking my testosterone every day, plus a few other things, because it isn't as simple as testosterone for men, just like it isn't so simple as to just take estrogen for women. No way. I did include us. It was a we.
Yeah, I caught that. And I like that, because there are men and there are women. And
you sure about that? Yes,
well, last time I looked,
a wide spectrum of all kinds of us.
Yes, there
are. We thought we were one human race, and we are, but we differ person to person to person to person to person.
Variations.
Yes.
Yes. Okay. So moving on to question number 3, and this is something we visited in our last interview, but I got a lot of different questions in regards to this. Can Dr. Rosensweet please talk more of bone health? If one has a diagnosis of osteoporosis, can it be reversed? Also, should other things be taken to reverse osteoporosis? And how long should it take to reverse osteoporosis? I definitely have it. The DEXA scan proved this to me, and I've not been on BHRT very long.
Yes, I like visiting this one. It's so crucial. And here's the thing. Bone loss is pretty much universal in men and women, because there's a lot of things needed to sustain bone health. And core amongst them are the hormones. And once bone is formed, it's not like this rock that's living inside of your body that never changes. No way. We tend to think of bone as sort of stable metabolically, and it's not. It's very actively dealt with, and once your bones form, there's a constant metabolic process involving bones, in which they're constantly being broken down and replenished by new bone. Very active metabolism. It's not proceeding at the rate of metabolism that red blood cells are, for example.
Right.
In young people, young healthy people, red blood cells are totally recycled every 3 days. You don't have a single red blood cell that you had 4 days ago. Mm-hmm. Different rates of dealing with this as we grow older. Well, bone is not replaced every 4 days. It's more like every 7 years, but it does have a periodicity to its being broken down and rebuilt and replaced. And one of the prime drivers of bone health is hormones, all of them. They all matter. And for women, let's just zero in on women, one of the principal drivers of bone health is estrogen. Mm-hmm. So when a young woman is losing her estrogen, you can count on her losing bone strength. It's measured in something called bone mineral density. Mm. Bone is made out of protein and minerals. Mm-hmm. And bone strength can be measured on an X-ray technique called bone mineral density determination. And you can see it on X-rays. I mean, we can do a chest X-ray, and very often the radiologist will comment, even though the chest X-ray was done to look at the lungs primarily, they'll say there is bone loss. They can see it. The bone doesn't show up as bright and dense as it does on someone who's young and has healthy bones. So bone loss, universal, you can count on it. Some of the most severe bone loss occurs in the perimenopause and early menopause. Ooh. First 5 years. And it's from estrogen loss. And then we also need testosterone for bone. We need progesterone for bone. Progesterone is the only biochemical that I know that promotes the action of the cells that lay down new bone. Estrogen works differently for bone. Estrogen slows down the metabolic bone dissolving process done by cells called osteoclasts. They're breaking down bone. Progesterone is affecting osteoblasts, which are rebuilding bone. So all these hormones, they matter. Thyroid hormone matters. Your diet matters. You got to have enough protein in that diet and minerals in that diet to honor and respect this rebuilding process that's going on. Oh, is there enough protein in people's diet? Varies individual to individual. And nowadays there's a major tendency for people to think that the healthiest diet on the planet is one that does not include heavy intake of protein. Not true. If you're genetically coming from a race that lived in the Arctic, for example, and you hunted for a living, and you're eating off of walrus and moose and caribou and all kinds of things, your diet was heavily based on dairy, for example, in Northern Europe, because that's what you could get in the winter. So genetically, those who were able to digest and absorb their food and get enough food, they tend to become metabolically very dependent on animals. Whereas if you're in the tropics and you've evolved century after century after century from vegetable eaters primarily, you can handle a vegetarian diet or a vegan diet. But I watch this error being made time and time again, and we want to be careful about that. Hopefully every individual is able to oscillate into the proper amount of protein and vegetables in their diet based on their specific bodily needs, and these can be determined. You can go on the internet and learn how to determine this. Now, it doesn't even matter what you eat in a certain sense. It matters what you're capable of digestion.
Right.
Uh-oh, midlife. We don't have the same digestive powers. In case you haven't noticed this, as young people. So very often we'll get into augmenting digestion of what you're eating. So we want you to chew, 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 chew. This is one of the most powerful things you can do for digestion is chew, and eat when you're not terribly stressed, and take your time and chew like wild. And then some folks will even go so far as to augment digestive enzymes and hydrochloric acid, because your stomach produces this powerful acid, and you need that acid to really digest protein properly and minerals. Minerals need acid. And then just a plug for organics, because food looks like food, and a piece of broccoli, whether it comes from agribusiness or organic farm, looks like broccoli. But
Right.
they are very different.
Right.
And they don't even taste the same. And an organically farmed piece of broccoli tastes loaded with taste. And a non-organic can taste like styrofoam. And the difference is in the minerals and the nutrients within there. So it depends on the nutrients in the soil. So why am I mentioning these? Because these are the crucial moving parts for bone. And again, we have a chapter on bone in the book. And there's a lot of moving parts there, but at the core of it is, as early as you can, as excellently as you can, in the perimenopause, ideally, start on these hormones. And it's very unlikely that you'll get any bone loss of significance. Can you rebuild this bone? Yes, you can. Our first goal is anyone who's losing bone to stabilize them so they stop losing the bone. Now, we can measure that. Like I say, this bone is metabolically being dismantled, broken down, and bone metabolites show up in the urine and in the blood. So we can do a test called DPD, or deoxypyridinolone. That happens to be a metabolite of bone. We can measure it in your urine. We don't want to see too much of that. We want to see deoxypyridinolone in your urine, a breakdown product of bone, because we want to see that there's active metabolism there. But we don't want to see too much of it. And if we do see too much of it, we investigate, why is there too much of deoxypyridinolone? Why is there too much bone breakdown occurring? And we investigate lots of things. Well, if there's no hormones in a menopausal woman or a perimenopausal woman, or insufficient hormones, bingo, that's very imperative that we stop this active excessive bone loss. Now, there's other reasons as well. Stress, biochemistry, Oigewalt dissolves bone.
Oigewalt, yeah.
So it also calls for increasing your skills and abilities to deal with emotional and mental and life stress. Because once you get skilled, we're not going to eliminate stress in human life. It has a very important function. It's really at the fuel from which most of us grow. It doesn't matter that we're stressed. It matters how well we do with it. And the real skill that's needed is that you don't trigger the biology of fight or flight every time you get stressed. Because when you get stressed, at the vanguard of the biology of that stress response, fight or flight, is two powerful hormones called adrenaline and cortisol.
Yes.
Oh, we need them. Absolutely. However, cortisol is known to dissolve bone. I remember as a medical student seeing a young man in his 20s having massive kidney stones in bed in University Hospital in Ann Arbor because of these massive kidney stones. And he had been on oral cortisol type medicine, prednisone really, for years and years. And he formed these, they were called staghorn calculi. They're stones in his kidney. And he was very, very sick from it. But that's the extreme example. For people who are on steroids, you're going to be losing bone. Well, that's not who I'm trying to single out here.
Right.
I want to single out those who are having an excessive biological response to the stress in your life. And this requires, for most of us, being devoted to our emotional and spiritual growth. And if you take on that particular subject, a big one it is, takes courage, takes time, takes energy, takes commitment of the highest order, then you will develop tools so that when the various emotional stresses occur in our lives, including from our own mind, we won't be triggering the biology of the stress response. The short version is we'll go, oh, I'm stressed right now. Well, I know what to do with the emotions and the mind part of it. I know how to let go here. So I'm hinting and pointing to a major skill set. And, you know, we live in an ideal time in history for this, because you can go on the internet and you can find teachers who are talking about emotions and the mind and life. And, oh God, it's so abundant. You could learn everything you need to know, pretty much all the practices you need to do. You'll have to put them in practice right off the internet. Why am I mentioning this? Because we don't want you to be melting your bones through excessive cortisol release. And then, yeah, the earliest that you can get into hormone replenishing, the better, though we never say never. You come up with it whatever age you do. And our first goal is to stabilize bone loss. And why have there's been such length to this particular answer? Because there's a lot of moving parts with bone. And then definitely you can replenish bone. We can see bone minerals density increase over time. Now, if you have osteoporosis, don't, you know, it's not another thing to get upset about. It's just something to let that upset fuel your commitment to taking care of your bones. And one thing that's important is impact exercise. For example, walking puts a little jolt. Every time your foot hits that ground, you get a little jolt shooting through your body. That's very good for bones. Whereas you don't get that same jolt from swimming or cycling, as good, as healthy as those exercises are, and they're phenomenally healthy. Anything you enjoy. But walking, dancing, this puts that little bit of stress on the bone, and that really helps bone stabilize. So exercise is a very important part of this as well. And, you know, if you've got osteoporosis, everybody should, and especially those with osteoporosis, should be tai chiing their way through life. That means when you're walking, when you're standing, when you're turning, you maintain enough consciousness of what's going on in your body that you are, number one, not reckless. Right. Number two, you're not putting your physical body in jeopardy because your mind is thinking about whatever and you trip over a log and crash. You want to be careful not to fall. You don't have to go wild, but you do want to be careful with your body, which is a great idea as you grow older anyway.
Of course.
I am so grateful for everything that still works. It's amazing. And I got a lot of stuff working and I love it. And, you know, I had to give up some of the extreme sports that I used to love to do, like skiing.
Yeah.
I haven't given up on skiing, but racquetball, it was a little bit too much for my non-20-year-old body because I'm not 20 years old. So caution, osteoporosis, caution, not compulsive nutball over concern, but yeah, well, these bones, just because you have osteoporosis does not mean you're going to get a fracture. Just because you've got it doesn't mean you're going to have some terrible thing happen to you. Throughout history, there are probably people with osteoporosis never knew they had it.
Right.
And did fine right up into their 90s. So you still got a lot of bone there and it's still holding you up. So I don't want you to get overly concerned about it. That's one thing about testing, as wonderful as it is. It starts revealing all these things that used to be called old age that nobody knew about, and they didn't worry about it. And they didn't, and that was helpful to not worry about every single thing that can go not ideal.
Yes.
Inside of us.
Yes.
The other thing that's really crucial to bones, oh God, really crucial, is muscles.
Oh, yes.
So I've told this story on our Facebook Live wonderful gathering every Tuesday and Thursday, most every Tuesday and Thursday, that I enjoy so much.
Thank you. Me
with
too.
This angel called Carolyn Shapiro.
Yeah. My wings are right back. I have to tuck them in.
Do you?
Yeah.
Well, they look highly polished today.
Yes. Well, thank you so much.
Because I can totally see them.
I know you can.
Or at
hopefully
least,
everybody else can. I tried to hide them.
Or at least I sort of imagine them there.
Thank you.
Because I remember this is 1968. I'll date myself a little bit here. I'm a senior in medical school. And I've got my white coat and my stethoscope, and I'm working primarily in the hospital. And we're going into the big hospital auditorium. Senior medical students still had to attend lectures. And we get a lecture from a gerontologist who said to us this, because I can remember this quote from this. I can picture this gerontologist saying, "You're senior medical students. You know 10,000 diagnoses. Let me tell you what's really happening to older people. They're losing their muscles. It's called sarcopenia. They reach a state where they can't stand or walk with stability. They're prone to falling, and they're falling on osteoporotic bones. They're fracturing those bones. And back in those days, that was pretty much the end game for
right.
Nowadays, surgery is so sophisticated that it isn't, but it's not good. So they identified that the real threat to bones isn't so much the osteoporosis, because so long as you don't fracture them, they're fine. They're going to hold you up. You're going to be able to walk. It's the muscles, and it's the muscle loss. And for those of you who wonder about it, anyone who's 60 years old or over, or maybe 50, do this. Go into a squat. And see if you can get into that squat, and see if you can stand up in that squat. Well, if you can't do that, get down on the floor and observe how you're getting up off that floor. Are you looking like a 16-year-old just springing off the floor, or are you having to use your arms and you're getting up pretty slowly? Or look in the mirror and take a look at the circumference of your thighs if you're not overweight. Or look at your triceps area. Is there flab where once there was muscle down there? You have sarcopenia if you're not on hormones, and you're going to have muscle loss. And the moral of the story is take care of the hormones, replenish the hormones that are so crucial for muscles. And that is androgens. And the queen of the androgens is testosterone.
Right.
Testosterone is not a male hormone. It's a human hormone, and women need it as strongly as men do. Not the same amount, but one of the services that we hold to be so crucial as we treat women in menopause is to replenish testosterone, because I can guarantee you, if you're 3 years without a period and you have not been taking hormones, 0 of you have adequate testosterone or DHEA. 0 of you. And most of you, if you're in the perimenopause and you're still menstruating even, have adequate testosterone or youthful levels of testosterone, adequate to preserve your brain and your your bones and your muscles. Adequate testosterone to preserve your muscles over the long run. So any program that you become part of, testosterone is a crucial part of it. As crucial as estrogen. So I did want to mention that about osteoporosis. You won't know it that you have osteoporosis, but you will know it if you get sarcopenia. And and this is that should be the signal. You should be able to sit in a chair and stand up without using your hands.
Yes.
That's another way that you can test this. But, why am I lingering on this? Because I think this is one of the most important things that we do. And I was talking to a doctor, Dr. Berkson, who's been on this show.
Mm-hmm.
And she and I were just aghast with what the beneficial impact would be on the American healthcare system and Medicare if women were put on hormones, and especially including androgens, because the United States has a tremendous number of assisted living facilities and nursing homes. And this is where the medical burden is to the healthcare system, the financial burden, because it costs a lot of money to sustain someone in an assisted living facility in a nursing home. And so many women would never need to. We were thinking 90% of women, we were making a wild guess, would never have to go into assisted living or nursing homes, could take care of themselves in their own home if they replenished hormones. So this is a big deal. This is something you want to get right. And, of course, sarcopenia can occur to the main muscle that holds up the bladder and the uterus. Yeah, that's a big deal, because as you get sarcopenia of that muscle called the levator ani, let's all identify our levator ani right now.
Please.
Why don't you guide us, Carolyn, in a levator ani identification process?
Not quite sure how to do that. You do it a lot better than I do.
Okay. Pretend you're squeezing your anus. Squeeze your anus right now and relax it.
Oy.
Squeeze it and relax it. And squeeze it and relax it. Well, that exercises the levator ani that's holding up your bladder and your uterus and your pelvis and your everything else that exists in that pelvis. And as you get sarcopenia of that bladder starts to fall, And that's one of two major causes of inability to control your urine. And that leads you to adults' diapers. And that's another reason why it's very difficult to take care of women in their homes. So sarcopenia is a big deal. So I want to shift our attention. I definitely respect osteoporosis and osteopenia greatly. However, I want to put our emphasis on sarcopenia so you'll protect yourself. You'll walk with stability. You'll stand in your kitchen and be able to rotate your body with stability and not do what my beloved mother-in-law did. At one time, she had sarcopenia, and she turned to the right in her kitchen, fell, fractured 3 bones: pelvis, shoulder, arm. So you may have osteopenia, you may have osteoporosis, but don't fall, and you'll be pretty good. You'll do pretty well in many instances.
Thank you for that. And the squeezing is important. And this is going to lead me into my next question. And again, welcome to all of our other ladies, Joanne and Desi and Ashley. See you and see what you're saying. And thank you very much for the kind words. This question, can we please discuss frequent urination in menopause? Many women have this. Many women think that they're having a urinary tract infection. And I want to correct this, but I'm not sure how. This frequent urination thing, it's definitely not a UTI. That's been ruled out. Is that part of the squeezing thing?
Precisely. What a segue. Squeeze. You'd almost think we had designed this, but we never did.
I know, but we didn't.
Because we don't.
That's right.
Not very much.
No.
Yes, it is. And, you know, it's a very, very, very common and unloved challenge in perimenopausal and menopausal women, especially as time goes on.
Yeah.
It has, like so many things, several things to attend to. One is when a woman loses her estrogen, 100% are going to develop vaginal atrophy. That means the lining of the vagina, which is very thick and has folds in it and is under, when you look under a microscope or even when you directly observe of it, it looks very healthy on a pelvic exam. And when a woman loses her estrogen, that changes majorly. That vaginal lining gets very thin and very fragile looking. And that can be seen on pelvic exam. And the common story that women experience if they're having intercourse is that, whoa, wow, when I was young, I lubricated. And now I have to use a lubricant. Or even more challenging, I'm uncomfortable when I'm having intercourse. In fact, there's pain even when I use a lubricant. That is from the loss of health of the vagina, which is preventable. Or if you have developed vaginal atrophy, restorable. Health is restorable by the proper replenishing of estrogens. It's wonderful. It's done every day. So don't be concerned about vaginal atrophy. Just get thee to your vaginal atrophy restoration program called Taking Estrogen. You get that estrogen right, that vagina is going to recover. Maybe not the youthful levels, but it's going to be plenty healthy. Now, one of the reasons the bladder gets involved, I do promise I wanted to get there because that was your question, is the bladder empties via a tube called the urethra. And the urethral opening is in the vagina.
Right.
So when you get vaginal atrophy, you affect that opening and you make it more irritable. You make it more delicate. It's subject to inflammation. And I'm glad that in this instance, this questioner has ruled out infection, because sometimes it gets so irritable, and that's the gateway to developing recurrent bladder infections or chronic cystitis. And so, if it really hurts when you pee, you don't want to leave out a trip to your local urinalysis assessment facility. Get your pee checked out there.
In other words,
you don't want to complicate irritable urethra with a recurrent infection. So, there comes a moment that you want to have that urine analyzed. But yes, it is also very common to just have uncomfortableness there, and also an irritability that's capable of triggering loss of urine called some form of incontinence, urinary incontinence. You cough and you lose your urine, you're losing control there. Now there's another major moving part, and it's the one, so let's do it again. Let's squeeze. It's that muscle, the levator ani. And there was a Dr. Kegel who suggested to women that they do exercises of that levator ani, and they're called Kegel exercises. And you know what? They're very cool. So I have patients that put a little sign by their toilet paper roll that says squeeze. And that means every time they go to the bathroom, they're squeezing. They're using that as a Kegel exercise to squeeze that levator ani to keep it toned up. Now you're going to have a heck of a time keeping it toned up, even with Kegel exercises. If you don't have androgens, you're going to lose that muscle.
Yeah.
So you're not going to totally lose it, but you can lose it to the point where it's not holding up the bladder well enough, and the bladder is dropping down, and that makes it super vulnerable to losing your urine, like when you cough, or even, eventually it's the recipe for adult diapers.
Mm-hmm.
So loss of urine, or inability to control urine, or having to urinate frequently, all relates to the health of the vagina and the health of the muscle that holds that bladder up. And you can keep yourself out of adult diapers all your life. You never have to see them, no matter how much real estate they take up in your local grocery store, because they do, in your local pharmacy, because these adult diapers are very popular. And every time you walk by that aisle, take a glance over there and squeeze.
Oh, you bet.
And be sure you get your hormones, because you need those androgens to keep that muscle in good shape. So, yeah.
It is indeed something we go over and over and over. I never, ever tire of it because of the huge importance.
Yes, exactly.
Dr. Rosensweet, honestly. And boy, oh boy. So that was a good segue. I mean, that was perfect timing on that one. The next question does come in, and I'm amazed here. So we've talked about cortisol. We've talked about high cortisol. We've talked about what cortisol is. But this question says, what does one do about completely rock bottom cortisol?
There is no such thing. So you won't have to do anything about it.
Okay. That was easy.
I'm being a little facetious.
Yes.
Every single hormone in your body that you can name, you could do without. Now, you wouldn't feel good and you'd have a lot of problems, but there's one exception, and that's cortisol. We all need cortisol to live. So if it was really rock bottom, you wouldn't be asking that question. So I know your cortisol is not. And like, for example, you could remove the thyroid gland and never replenish thyroid, and a person would live. They'd probably be in bed 100% of the time, but they would live, but not cortisol. We need cortisol to live. And rock bottom cortisol, where it's too low, is got a name. It's called Addison's disease. John Kennedy had Addison's disease. He was successfully treated with cortisol every day. He didn't have enough cortisol. What wore him down? Why did he lose his cortisol? Because he put excessive demands on his adrenal glands to where they couldn't keep up with it. And he had a challenging life, President Kennedy.
Yeah.
So rock bottom, it's not. Now, what is extremely common is lower cortisol, lower than optimal. And that happens by excessive pushing, demanding that the adrenal gland mobilize for fight or flight day after day after day for so many years that the adrenals eventually can't keep up with the amount of cortisol that the body would consider to be optimal. It can't keep up production. This happens in all kinds of functions and organs in our body. We put excessive demands on for years. When we're young, we can pump out.
You're kind of going in and out.
High levels that we're calling for through our fight or flight. But after a while, we can't keep it up. And we start getting depleted hormone levels of things like cortisol. Now, cortisol is such a high priority that it's going to be the last to go. Your body is going to recruit and drain your estrogens, your progesterone, your testosterone, your DHEA, your thyroid, and cortisol will be the last to go.
You're kind of breaking up, Dr.
Can you hear me now?
Sorry. I can hear you now. Yeah, you're a little fuzzy, but we're hearing you.
Can you hear me now, Carolyn?
I can.
Okay. So cortisol is going to preserve at the expense of every other one in your body. Now, a lot of people come when we test them in their perimenopause, and they've got elevated cortisol metabolites, and that's how we like to, and that's my favorite way to do it. Yeah, let me see if I can do something about it. I'm going to try closing some other stuff I got open and see if I can improve what I've got open. I'll say that occasionally in the perimenopause, when we test women, they have adequate or even elevated cortisol.
Right.
That's not that common, but what it does show us is they've got very healthy adrenals that are still cooking. Ooh. Now, there's good news that they still do, but it's not. The not good news is they're creating elevated levels of cortisol. That's eventually going to wear out that adrenal gland, and it speaks to them not being very skilled at being able to deal with the stress in their life, and that's consequential. But more often than not, we start seeing cortisol depletions. But the interesting thing is because cortisol production draws on the same raw materials that estrogen production does, and testosterone production, progesterone production does, that if in a perimenopausal or menopausal woman that the cortisol is slightly low, we don't have to give the patient cortisol. We can just replenish the estrogen, testosterone, DHEA, thyroid if needed, progesterone, and we will observe over time that the cortisol will recover all on its own. And that happens in my practice 90% of the time of women who show up not with rock bottom. They're not showing up if they've got rock bottom cortisol. They're not. But if they've got low cortisol, we don't have to treat with cortisol in most instances. We just replenish the estrogens, androgens, progesterone, and thyroid if need be, and testosterone, and the cortisol will recover all on its own. Now, it's a rare instance, and there are women and men who've had so much stress in their life that the cortisol is so low that we decide right out of the gate to also treat them with cortisol. Now we're replenishing simultaneously the estrogens, progesterone, and testosterone, DHEA, and if needed, thyroid. And we keep an eye on these women that we're supplementing with cortisol, because they're going to heal, and we don't want to get them into excessive cortisol. So we're testing them every couple months to make sure that their own adrenal glands haven't recovered to the point where they no longer need the external cortisol. In fact, that external cortisol is getting them into elevated levels. So we watch those patients like a hawk if we're going to treat them with cortisol. Not very common that we do. I'd say 1% of the women I've treated over 25 years do we actually give them cortisol, even though we observe low corticosteroids. We just replenish the other hormones and we watch those corticosteroids recover. But at 1% of the time, we will treat with cortisol, and we need to treat with cortisol. And that's an esoteric subject for the experts to be able to make that discrimination, also be based on testing.
Oh, yeah. Yeah, I can well imagine. Well, we're kind of at that bewitching hour. We have a couple of more.
You know what, I hear too, I've got another super hard stop this morning.
A super hard stop.
Yeah,
But that's got to be a hard stop then.
Yeah, so we should probably make it a wrap for today.
A wrap?
And
it's a wrap.
I'll get to the other questions, and such a pleasure doing this with you, Carolyn.
Oh my God, Dr. Rosensweet, honestly, it is a pleasure on my end too. Tuesdays and Thursdays, those are the days. Those are the days. Would you kindly be good enough to snapshot?
Of course I will, yes.
Yes, and then I can answer these questions of these wonderful women that have put them all up. And I have my work cut out for me, and we'll get to you, and we will see you again. Have a great weekend.
You
everybody.
Too, hi to Daryl, and I'll see you on Tuesday.
Indeedy, you will. Have a great weekend, ladies. See you later. And if there are any men up here, you guys too. Bye.